ahead and get started. And again, this is just basically an introduction about correlating clinical dermatology and dermatopathology. And so basically, there's a lot of people out there who sort of don't really think that derm is that hard. They sort of think that anybody can do it. You know, you can be a PA and spend a year in a sort of a preceptorship and boom, you're a dermatologist. And, you know, it's really underappreciated. And this quote by Goethe here that you can read is just sometimes just seeing what's in front of you and sort of describing it, determining it, whatever, that can be sometimes the hardest thing to do. And so I remember when I was a resident way back in the old days, long before you guys were born, I mean, people didn't really view us as really being doctors. You know, I remember when I said I was going to go into derm, they said, oh, you're going to go into a field that you're not even a real doctor. You know, they wanted me to go into internal medicine, all this kind of stuff. But today, I think a lot of people have more of an appreciation for dermatology, but a lot of people sort of think anybody can do it too. And that's not really true. So if you're going to master anything, it doesn't matter what it is, sports, foreign language, musical instrument, you have to have an approach. You have to, I think these four keys really to mastering anything, having a solid sound approach, and that's what we're going to kind of go over here today. Then you have to learn the details. So you have to actually spend time studying, looking at slides, memorizing, and a lot of memorization into residency. You got to practice a lot. And it is called the practice of medicine for a reason, because if you quit practicing it, you'll get stale. So you have to practice it as long as you want to stay in the field. Quit practicing, you lose. And then you have to learn from your mistakes. And that's in a residency program, really, you know, you're in a very safe environment. And so whenever you make a mistake, instead of beating yourself up about it, you should really almost kind of celebrate that, because you will, you'll remember that for the rest of your life. I still remember mistakes I made as a first-year resident when I got called on in grand rounds many years ago by Dr. Rudolph Baer, you know, 40 years ago or plus now. So those things stick with you. I don't remember the case that I got right as much, but I do remember the case that I got wrong. And so sometimes those are good learning experiences, and you'll remember those. And then you learn from those when you find something that you approach something the second time you see it. You don't make the same mistake twice. So this little thing here, my wife bought this a few years ago, sing loud when you don't know the word. So I want you guys to feel like in this conference, you should be comfortable if you're not sure of something. And we're not trying to beat people up here. We want you to basically, you know, feel safe, and you can make mistakes in a safe way. And I promise I'm not going to make you feel dumb. And we want you to learn. So basically, if you look at, you know, dermatopathology, it's comprised of two pieces of it. There's the dermatology part and there's the pathology part. And you have to know both. Now, you don't have to be a board certified pathologist to know dermatopathology. You do need to know some pathology, though, to do dermatopathology well. And if you're going to be a good dermatologist, you have to know dermatopathology. And that's what separates us from the non-dermatologists out there that practice, the pretenders to dermatology, if you will. They don't know histopathology. They don't know dermatopathology. And that's the real core to what we do here, is being able to look at things, correlate what we see clinically with the pathology, because the biopsy is our number one test in this. It's not EKG, it's not that sort of thing. It's basically correlating clinical with histology. So our method here, if we're going to, you know, develop and use a method, as we mentioned before, learning your mastery here. When I was training years ago with Dr. Ackerman, who's one of the giants of our field in dermatopathology, when I was a resident, we actually came up with a clinical pathologic correlation type approach for learning dermatopathology. It was called Learning Dermatopathology through Clinical Dermatology. And so we developed an algorithmic approach. And we all talk about algorithms today and the internet and all this, that, and the other. But if you really go back to looking at what the true definition of an algorithm is, it's basically a step-by-step procedure, really mainly in math, for doing calculations, for reasoning. But it's also useful in clinical medicine for diagnosis, where you take one bit of information, another bit of information, another, and you add it up to come up with an accurate diagnosis. And so in morphologic fields like dermatology and dermatopathology, we use pattern analysis very commonly. And basically, Dr. Ackerman basically was one of the guys that sort of propounded this years ago. And the reason is that if you take a look at the universe of skin diseases, there's a lot of them, and many of them have overlapping clinical appearances. So that's why when you see an internist that describes a skin eruption, they'll call it a maculopapular eruption. Well, they'll call everything maculopapular. You know, they don't understand the difference or the subtleties between those. And there's also overlapping histology between these. And so because there's all that together, they do tend to sort of fall into certain themes and patterns. So there's recurring clinical features, recurring histologic features. So once you kind of learn those patterns and those categories, you can then actually use them to help you when you see something to put it into this category, and then use information, more algorithmic information, to arrive at a specific diagnosis. And we always start at a low magnification, and always recommend too, starting with the least amount of information initially, where you're just looking. Patients, you know, it's great to sit at a bedside and take history and stuff like that when you're trying to, you know, discover somebody's heart disease or their GI problem or anything like that. But when you're dealing in dermatology, it's really better to just look first, because patients will sit there and they, not that they're pathological liars, but they say things that clearly aren't true. You'll be sitting in the room with a patient, does that itch? And they'll say, no, while they're scratching. Or they'll come in with a lesion that's maybe the size of a baseball and say, well, how long has this been there? So, well, it came up yesterday, you know, things like that. And you know, that's really false. And so you have to basically sort of turn the volume off a lot of times, patient history, and just use your morphologic diagnostic capability. And being many of you first year residents, for example, you're probably just getting off of an internship in, say, internal medicine or something, where you really didn't deal with morphology. You're used to looking at blood test results and EKGs and x-rays. And that's different in dermatology. You have to sort of turn off the internal medicine part a little bit and learn how to use pattern recognition. And so, and again, Dr. Ackerman again used to say low power diagnosis, high power mind. So we're going to always start off with low power. And so his analogy was really kind of learning. He used to talk about when you're going bird watching. I don't know if any of you guys have ever been bird watching. But if you go try to see birds in the air, they're flying, they're sitting in trees far away, and you don't see all the spots on the bird or the close elements of the bird. You just kind of see their silhouette. And of course, birds have different silhouettes, and you can kind of look at that, like these little pictures here, and you can say, wow, yeah, I can recognize what type of bird this is generally going to be just by its silhouette. And then you go to higher magnification, if you will, and you start looking at some of the more other features, the more defining features, to make a more specific diagnosis. So you can kind of look at that picture and kind of get it into the sparrow category. But then when you take it and maybe capture it, you know, when you look at a higher magnification with a high powered camera, for example, or with binoculars, well, maybe you see some of these markings and you say, it's a, you know, this type of sparrow versus that type of sparrow, et cetera. So we do the same thing in pathology. So the first thing we do, sometimes we'll even just take the slide and hold it up, even without a microscope. We're just looking at it from a distance. And then we don't do that all the time, but sometimes we will do that. We may want to see how many sections are on the slide. So we may look at the slide and say, well, would this have been a macule, a papule, a nodule, a big giant tumor, that sort of thing. So that's something we might even do even before we put it under the microscope. But we always want to look at it without any history. The minute you get history, unless you got a really bad case of short-term memory loss, you're going to be biased. And it's hard to take that and sort of forget about that. So we always look at the slide without history first. Now we're going to look at that history eventually, but first we look at it without any information. And then we do some preliminary sort of things. We say, well, what's part of the body is it from? You know, certain diseases like to involve certain body sites. You don't get dyshidrotic dermatitis on the scalp. You know, it's on the palms and soles, for example. We ask ourselves what type of biopsy is performed. Is it adequate for diagnosis? And sadly enough, we get more and more biopsies that are not adequate for diagnosis. And a lot of those are taken by people that aren't dermatologists because they don't understand that you need a punch for inflammatory things. I think you can take a superficial shave biopsy for something like a panniculitis or alopecia, for example, and clearly that doesn't work. A shave or saucerization is good for neoplasms, but it's really not very good for inflammatory processes. If it's a really large neoplasm, you may have to do an incision biopsy or even an excisional biopsy. So you have to ask yourself, well, is this biopsy going to give me enough information? And unfortunately, there's some limitations in our technique, and those get even further increased when we get an inadequate biopsy, and even further when we get zero information, as we'll talk about a little bit later. So the first thing we do when we get this biopsy, we've done those preliminary things. We say, well, let's see if we can actually analyze it. So let's assume we can. And we ask ourselves whether we think it's more likely to be an inflammatory process or a neoplastic process. And I'm going to go through those things with you almost every time when we look at an unknown slide. Even if it's a basal cell carcinoma, I may ask you, well, do you think it's inflammatory or neoplastic at low magnification? And you may say, well, that's sort of a waste of time, but it's just like, in the movie Hoosiers. I don't know if you guys have ever seen that with Gene Hackman in there. He makes them dribble, he makes them run, the lines, all this kind of stuff. And they all think that's stupid. They should be out shooting 3-pointers, but the fundamentals are key in this. And you have to just go through it time after time after time until you really it becomes second nature to you. So I encourage you to do that. And eventually it'll become second nature. So step one, inflammatory or neoplastic. And it's not always easy. A neoplasm will always have some neoplastic cells. Obviously, an inflammatory condition is going to have just purely inflammatory cells, but sometimes you get both. You get a neoplasm that's got a lot of inflammation in it, like a halo nevus, for example. That looks like an inflammatory condition, when you first look at that, and you have to look carefully and you see the nevus cells in there. There's a few conditions that don't really fall directly into one or the other. Is vitiligo, for example, is that an inflammatory process? Maybe it is, but there's certainly almost no inflammation when you see that. And of course, we have tattoos and malformations. But it's a really good, easy, general thing to do. First of all, I like to keep it simple. So is it inflammatory or neoplastic? And if you look at neoplastic processes, they tend to have discrete aggregations of cells or nests. We see these, or they may be a diffuse arrangements of these epithelial or mesenchymal cells, whereas the inflammatory processes are comprised of inflammatory cells, as we mentioned before. And they tend to arrange themselves in one of 9 primary reaction patterns. Now, Dr. Ackman, in his later editions of his textbook, expanded those patterns. I didn't ever move there because I sort of thought that he was taking subsets of the 9 major patterns and then turning them into new patterns. And I thought it was better to keep it simple. So I still teach the 9 patterns. We're going to go through those here in a second. So we're at this stage now. We're looking at the pattern of inflammation. And again, I'm going to ask you over and over again, okay, which one of these patterns is it segregating into? So you're going to be asked that question over and over again when you're looking at these slides. So we want you to know these patterns, and there's not 19 of them. There's only 9, which is good. So it's better not to have a lot of them. And then you want to look to see what kind of inflammatory infiltrate is present. Is it mixed? Is it predominantly one of these? And if you can take all that information and put it together, you can come up with a specific diagnosis most of the time, which is good. So it's helpful. And you can really, the better the diagnosis, obviously, the better your treatment of the patient. And it's not 100% of the time. We can't always get a specific diagnosis, but certainly we can get into one of these categories most of the time, and we can narrow it down and many times make a specific diagnosis. So these are the 9 patterns. I'm not going to read this to you, but we're going to go through these. So the most common pattern is this: superficial perivascular dermatitis. And we ask ourselves, well, if it's got this pattern, does it have epidermal involvement or not? And a lot of times you'll see this with almost no epidermal involvement. And a good example of where we see this is like a morbilliform drug eruption or like a viral exanthem. You'll see the sparse perivascular infiltrate like in that little cartoon here. So this is what this is. And so when you see this, rather than just kind of saying, oh my gosh, I have no idea what this is, you can say, well, I know what this pattern is, and I know what these diseases are that can theoretically cause this pattern. And that's kind of how that works. And this was an individual that did have an urticarial drug reaction, which is a very common cause of this pattern. You ask yourself next if there's any epidermal involvement. So and this is very important as well. I mean, when the epidermis is involved, that's when you get something that you can see clinically. Scale, it's maybe crusted, maybe it's oozing, maybe there's some kind of thick cornified material on it, like a horn or something like that. So, the epidermis is involved when you see some of those kind of changes in there. And the three main types that we see that are associated with the superficial perivascular dermatitis are interface change, we'll talk about that in a minute, spongiosis, and then psoriasiform hyperplasia. Now, there are others, but again, this is an overview. We're just going to mainly go over these few today. And then, these are all the other things that you can see, which we're not going to talk about, but you will learn about over the course of the next year, 2, 3 years. So by the time you're finished, ready to take the boards, you're going to have heard about all these, and you're going to see diseases that show all of these in there. Now, we're talking about interface. We mean the interface between the epidermis and the dermis. So that junction right there. And there's two forms of interface dermatitis. There's vacuolar, where there are little holes in the basal cell layer. And then it's lichenoid, where there's this dense infiltrative cells that obscures the dermal junction. So this would be an example of lichenoid in this diagram here. And here you see an example of vacuolar. You see those little holes there to the right, these little structures right here. These are vacuolar alteration of the dermal junction. And again, we see that in a relatively few number of diseases. And this is lichenoid dermatitis. This is lichen planus, which is the classic sort of prototypical example of a lichenoid dermatitis. The most common epidermal reaction pattern that we see, probably this and psoriasiform are pretty close, but I'd say probably the most common that gets biopsied, the most common that patients develop diseases of is spongiotic dermatitis, spongiosis, where there's collection of fluid between the keratinocytes. And so this is eczema, basically. Now eczema, again, I don't like the term eczema because I don't know what it means. It's basically histologically, we see spongiotic dermatitis, and then you see that same reaction pattern, meaning that it's a pattern, the way the epidermis can react to a stimulus in things like atopic dermatitis, contact dermatitis, nummular dermatitis, id reactions, spongiotic drug reactions. So there's a number of entities that can give you this spongiotic reaction pattern. And so when somebody sends something into me as eczema, I don't really know what they mean. The lay world uses eczema synonymously with atopic dermatitis. But this guy on the right doesn't have atopic dermatitis. He's got allergic contact dermatitis. And a lot of those things get biopsied and submitted to us as eczema. Well, I don't know if you really mean atopic dermatitis or you mean contact. So we recommend putting down the most specific clinical information possible. So if you really think it's contact dermatitis, put that down. And it's very difficult for us to tell the difference between chronic contact dermatitis, allergic contact dermatitis, and atopic dermatitis. So again, we want you to be precise in your language also. The next pattern that's very common is psoriasiform hyperplasia of the epidermis. That basically means that it is hyperplastic epidermis that simulates psoriasis. So sometimes we take a disease and then we say, well, other diseases kind of look like the prototypical disease, predicate disease. So something looks like psoriasis, but it isn't psoriasis. We call that psoriasiform. And there can be actually two different types of psoriasiform hyperplasia. It can be regular, where the epidermal rhescia are really quite similar in length, very elongated. They all look about the same, or irregular, where they look, one's thicker and longer than the other. So different diseases will tend to give more regular psoriasiform hyperplasia, like psoriasis. This is what this is supposed to be, say, versus something like lichen simplex chronicus, which gives you a lot of irregular epidermal hyperplasia. So this is psoriasis histologically, and you're going to see lots and lots of biopsies of psoriasis over the course of your career. Now, the next pattern is superficial and deep perivascular dermatitis. And this is the perfect example of why we don't like shave biopsies for inflammatory skin diseases. If I get a shave biopsy of this, I can't comment on the deep component of the specimen. So when people say it's okay to do a shave biopsy of inflammatory skin disease, you should tell them that it's not okay to do that. And really need to take a punch biopsy, and it needs to be a good punch biopsy that goes all the way down to the subcutaneous fat, because we need to see how deep that inflammation goes. And different diseases will give you different, they involve the epidermis and the dermis higher or lower. So we really do need a punch biopsy for inflammatory diseases. And this is a patient that has discoid lupus erythematosus, got a superficial and deep infiltrate here. If I just had a superficial shave of this, I couldn't make the diagnosis. And that basically is not good for the patient, because then they got to come back. They're still living in mystery. We don't know what the diagnosis is. So give your patient the best chance at the best accurate diagnosis by giving them the best possible biopsy when you take it. Another pattern is nodular and diffuse dermatitis. That's where the infiltrate becomes denser and starts forming little nodules in the skin. And when those nodules kind of coalesce, well, then we call that diffuse dermatitis. So those are kind of maybe on a spectrum, if you will. And once again, you need a deep biopsy here to be able to appreciate that this is a diffuse nodular process. If you do a shave biopsy, you can't tell that. So this is an example of nodular dermatitis. See these little nodules here, and the nodules are comprised of epithelioid histiocytes, and this is sarcoidosis in this case. And here you see a patient with that. But you can get nodular dermatitis with neutrophils, you get nodular dermatitis with lymphocytes. So this was a patient that has a dense nodular diffuse infiltrate with neutrophils, and this is sweet syndrome. So both of those are examples of nodular and diffuse dermatitis. Vasculitis, okay, that's its own separate histologic pattern. And there can be a number of different classification schemes of vasculitis. But histologically, when we see this, we say, well, you know, it's the blood vessel is actually involved in the process. There's inflammation of the blood vessel itself. So it's not just perivascular inflammation. The blood vessel itself is damaged. And the histologic definition of a fully developed lesion of vasculitis, it has to have fibrin in the blood vessel walls with or without thrombosis, with variable amounts of inflammation. And the prototypical example is, as you, I'm sure, have all heard the term, is leukocytoclastic vasculitis, which gives palpable purpura. And you can see that pink material right here that's in this blood vessel, and this one too, is fibrin. And all these little sort of things look like pepper in the dermis. Those are breakdown products of neutrophils. So that's leukocytoclastic vasculitis. And again, that's just a histologic pattern. Clinically, they can get all sorts of lesions in addition to palpable purpura. They can get pustules, blisters, nodules, so a lot of different clinical manifestations of vasculitis, but histologically, it can give that type of pattern that you just see there. The next pattern is blistering in the skin. And we get a blister in the skin, we ask ourselves whether it's within the epidermis or if it's beneath the epidermis. And so this is intraepidermal vesicular dermatitis, and we lump vesicles and pustules together. So something is actually within the epidermis, either just fluid, or if it's got neutrophils or lymphocytes or something like that in there, we talk about that as being intraepidermal. And there are three main patterns that we see for intraepidermal vesiculation, and that's the first three. Spongiosis, we mentioned before. Ballooning is where you get intracellular edema. That's where liquid gets inside the individual keratinocytes. And then acantholysis, where you get the desmosomes that hold the keratinocytes together, break apart. And that the word acanth is the Greek word for spine. So when we think of acantholysis, it's like the little spines that hold the keratinocytes together. Those are dissolved. There's a couple of others: epidermolytic hyperkeratosis, intracellular shearing, et cetera. You'll learn about those, but the three main ones are those top ones. And this little diagram here kind of shows those. And it also kind of points out that a small vesicle can get bigger with time and then lead to a blister. But you can see the spongiosis, a collection of fluid between the keratinocytes, the ballooning, the filling up of the cells, like blowing up a balloon, and then acantholysis, where the cells fall apart from one another. And then you say at the bottom, I'll talk about subepidermal blisters in a minute. So this is herpes simplex virus infection, which actually gives two different types of patterns. It gives both acantholysis, where the cells fall apart from one another, and ballooning degeneration. So all these large multinucleated giant cells here, these are ballooned keratinocytes. So that's both in that situation. The next blistering process is beneath the epidermis, subepidermal. So here you see this, and these are very common entities you're going to be facing as well: bullous pemphigoid and immunobullous disease. So there you see the blister is beneath the epidermis, and it's got an infiltrate of eosinophils and lymphocytes in the infiltrate. The next pattern is fibrosing and sclerosing. Okay, now, so this is still inflammatory skin disease, But sometimes the inflammatory cells are mostly fibroblasts and histiocytes. So it doesn't always have to be lymphocytes, neutrophils, eosinophils. Sometimes it can be fibroblast, fibrohistiocytic proliferation. And so again, this is where the fibroblasts are playing the most important role. And there's a distinction between fibrosis, which is an increase in collagen and fibroblasts, and sclerosis, which is a decrease in fibroblasts with homogenization of collagen bundles. And that's important to make that distinction, because different diseases will give you different patterns. And morphia, for example, is a sclerosing process. You get a decrease in fibroblast, but an increase in collagen, but those collagen bundles are homogenized and really thick sclerotic skin that you see there, like on the right. So that's an example of sclerosing disorder. The hair follicles can be involved, and we talked about that being both folliculitis and perifolliculitis. So if the follicle is involved inside the follicle, the lumen of the follicle, we talk about that as being folliculitis. If it's around the follicle, we talk about that being perifolliculitis. And, these are some examples of those: acne, bacterial folliculitis, those are the follicular involvements. And then perifolliculitis would be a good example. That would be lichen planopilaris, for example. That's where it involves the tissue just right around the follicle, as opposed to being in the lumen of the follicle. So here's an example of tinea, which was a folliculitis. And the last pattern is panniculitis. And the fat is really comprised of two different components. It's got the lobules, and then it's got the septa. And so you get inflammation that can involve mostly the lobules or mostly the septa when you're looking at panniculitis. And once again, notice if you're going to get a biopsy to evaluate if panniculitis, you can't do a superficial punch or shave. You have to do a deep punch, and it has to be, you have to kind of bury the punch down to the white plastic, part of the punch. You can't just barely get the metallic part of the punch in the middle of the reticular dermis. You won't get deep enough. So you got to take a deep punch biopsy or an incisional biopsy. And so these are just a couple of examples where you can get, and we also talk about panniculitis with or without vasculitis. I'm not going to go through all this today, but you're going to learn all about this as time goes on. And this is the classic example of a septal mostly panniculitis. We talk about septal mostly because there's usually always a little bit of periseptal inflammation, but this is erythema nodosum, which is the prototypical septal panniculitis. Okay, so once you define those inflammatory patterns and you've asked whether there's epidermal change or not, and these other other things like if it's panniculitis, where there's vasculitis or whatever, we ask ourselves what's the composition of the infiltrate. Certain disorders tend to have more inflammatory cells of one type than another. For example, the sclerosing disorders, every sclerosing disorder that you'll see, like in sclerosis, morphia, necrobiosis lipoidica, they all have plasma cells in there for some reason. I don't know why that is, but they do. So that's important. And then like bullous pemphigoid I mentioned before, tends to have eosinophils. So we ask ourselves what type of cell is involved, and that's helpful. If you see a subepidermal blister with neutrophils, for example, that's less likely to be pemphigoid and more likely to be something like DH or bullous LE or linear IgA. So it's helpful. You can see the same pattern, but then you ask yourself what type of cell is in the infiltrate to get a more specific diagnosis. So basically, go through this systematically. Look at it first without any information, formulate a differential diagnostic short list, and then you look at the clinical information, and then you try to put those two together. So that's how we do it. And that's with the inflammatory part. Now let's look at the right side of the chart here. And let's talk about neoplasms, because obviously a lot of biopsies get taken for cancers and whatnot. So we're going to ask ourselves the most important question: is it benign or malignant? And how do you tell that? Okay, well, so you need to know that. And then the good news is that at low magnification, benign lesions tend to be small, symmetrical, well circumscribed, and superficial. You can remember that. It's only 4 little things there. And malignant is the opposite. They tend to be large, they tend to be asymmetrical, they tend to be poorly circumscribed, they tend to be deeper or extend more deeply. And so, of course, there are exceptions to every rule here. But these are the general patterns. And again, we start off at low magnification here, looking at this. So you don't start off at high magnification. I'm not going to let you start off at high magnification. Let's make you go through it at low magnification first, and then we're going to go to higher magnification. And a lot of times you can make that diagnosis immediately at low magnification, but this has to be malignant. And then you go to higher magnification, you prove it, but at least we start off that way. And then these are some other features too. I'm not going to go through all these either, but they're helpful in sort of further defining this when you go to higher magnification. Okay, so let's look at some benign lesions. So this is a seborrheic keratosis, shaved biopsy. It's very symmetrical. It's small. It's well circumscribed. It's got all the features of the benign process, sebaceous hyperplasia. So again, this obey the rule of this dysplastic nevus, and then this is a little benign neural neoplasm. So all of these show those classic features of benignity. Now, malignant lesions, everything starts small in the skin, but they can get bigger over time. This is a actinic keratosis that wasn't treated and gradually can turn into a squamous cell if you leave it there long enough. And some cancers are malignant not because they have a tendency to metastasize, but just because they tend to be locally aggressive, like a basal cell carcinoma. Those almost never metastasize, but they can cause a lot of problems. When we're looking at melanocytic lesions, we apply the ABCDE criteria that you learn about in clinical dermatology histologically. So again, they tend to be broad, asymmetrical, poorly circumscribed. We see irregular pigment. The diameter is usually greater than 6 millimeters. So we see all the histologic features that we see at low magnification when we're looking at a patient with a dermoscopy, for example, or seeing them in the clinic. So histologically, it correlates with what we see clinically. So once we decided whether we think it's benign or malignant, we ask ourselves, what kind of differentiation is it exhibiting? Is it epithelial or non-epithelial? Okay, so that's, how do you do that? Well, epithelial differentiation, the cells tend to be more kind of like little squares. They tend to be cuboidal or columnar. They tend to like one another, so they really adhere to one another. Epithelial structures in our body tend to be things like the lining of ducts or glands, or they tend to be our skin. So they tend to be like little building blocks. They're kind of performing a little, they're structures, if you will. Non-epithelial differentiation, these tend to be more spindle in shape. They don't tend to have as much cytoplasm. They're not really hugging one another, so to speak. They may have kind of a mucinous stroma. And then, of course, the bone marrow elements, those are all non-epithelial structures. So when you're asking yourself that, you say, well, does this look more kind of like building blocks, if you will, or do they look like spindle type cells, or do they look like maybe blood cells? So squamous epithelium, that's a type of epithelial differentiation. Basaloid differentiation, like the basal cell carcinoma in the down here. This is a sebaceous lesion. These are all different types of epithelial differentiation. And neuroendocrine differentiation, those are all epithelial. So those are different types of epithelium. And then non-epithelium, things like fibrohistiocytic, neural, vascular, muscle, fat, and then the bone marrow derived elements. So again, notice these are more spindly in shape as opposed to being more like little squares, if you will. And sometimes things don't read the textbook necessarily. You can get like the mesenchymal neoplasms that can give you an epithelioid morphology simulating epithelial differentiation. But that's the exception rather than the rule, and you'll learn about that. And then the last thing, obviously, we ask ourselves about specific differentiation. If we're not sure, we may end up having to do additional studies. So just a few sort of final sort of things. If you're not really sure, describe what you see and put a differential diagnosis down. So you're not always going to be able to come up with a definitive answer every single time, but you can come up with a differential diagnosis, and you want to keep it short and sweet. You don't want to have like a laundry list of things. You want to kind of keep it short and sweet. And sometimes you may think you know something that's there. You may be searching for something that's there. I know this looks like a suppurative granulomatous dermatitis with epithelial hyperplasia. There's got to be an organism in here somewhere. So that's where you're searching. You know it's got to be infectious. You're searching for a bug. That's one sort of brain subtype. The other is where you're solving the problem, where you're looking and say, well, what's this pattern? What is this going to be? Is it maybe an infection? And so you're kind of solving. Those are two different brain types. And so you kind of brain functions, and you kind of need to have different cues and clues, if you will, to be able to kind of arrive at a specific diagnosis based on those. Okay, so that's the pathology part of it. That's when you're approaching it, looking at a slide. Let's talk about the clinical derm side of it. Okay. And you're going to learn this from other people also that teach this, but basically because it's dermatopathology, because you have to have the clinical dermatology part of it to be able to do dermatopathology, it's important to have an approach to this as well. And it's really very similar when you're seeing a patient. It really should be kind of very much like what I just described when you're looking at a slide. You need to start looking at a patient from a distance. When you first walk into the room, you're gathering information about the patient. Even the way they say good morning to you or hello to you, that's information you should be instantly registering in your brain right then. So when you go in to see a patient, it's like, you know, a professional golfer getting ready to tee off for the British Open coming up tomorrow. Yeah, they're like, you're prepared. You're getting ready to go see that patient. Maybe you've heard the basic information from the MA or from somebody else you're working with, but you're ready to kind of go to work immediately when you walk into that room. And then you move progressively from low power to high power. Don't just walk in and instantly stick your nose on their skin lesion and pull out your dermatoscope. Start from a distance and gradually move in. And then the last thing you want to do is kind of picture in your mind where the pathology is going to be. If you're going to have to take a biopsy, you have to know what kind of biopsy to do, where that pathology is going to be. And then you sort of put everything together to make a final diagnosis. So the first step again is looking at the general appearance of the patient. Look at the distribution of their skin lesions. Are they localized? Are they widespread? So, you know, these pictures here, I mean, this guy, look at his eyes, you know, he's got a scar there on his neck. So why is he there for a skin disease? Well, guess what? He's got this stuff going on in his pretibular. He's got pretibular myxedema. He's got Graves' disease. And look at this guy, you know, picture's worth 1,000 words here. You don't even have to ask, how are you feeling today, Mr. Jones? You know, he doesn't feel good. He feels terrible. He's got a drug reaction there. So that was his diagnosis. And then the distribution of lesions is also very, very helpful. Sometimes sometimes one of these little elements can be the most important in making a diagnosis. So we like to take all the information and put it together, but sometimes something trumps everything else. So if you see that somebody's got a distribution of something like on this far right picture, that's a classic photo distributed area, that's going to narrow your differential diagnosis down dramatically. So that might trump, say, what the clinical lesion looks like, the high magnification, the morphologic of the primary lesion, for example. So you want to remember what this distribution is. That can be very helpful also. So this is a classic location for a rheumatoid nodule in this person, the elbow. Doesn't have anywhere else, just has it here. So that's a localized area with a classic distribution. This is another pretibial eruption. This isn't pretibial myxedema. This is lichen amyloidosis, which tends to love that area. So some diseases really, they just target certain specific parts of the body. Here's a photo-distributed eruption. This is a woman with lupus. And as you talk about a picture being worth 1,000 words here, I mean, she's got Cushingoid appearance because she's on steroids. She probably went off her steroids, went outside, got a flare of her condition. Her lips are eroded. I mean, she obviously feels terrible. So again, you can just pick up a whole lot of information just from looking at that based just on her distribution right there. And then that's just localized distribution. A lot of times things can be widespread. They can be unilateral, bilateral. They can have classic distributions like along the lines of cleavage. If I tell a second or third year resident that, they instantly think of pityriasis rosea. They can be diffuse processes, erythrodermic, universal conditions. So this is pityriasis rosea. Notice that sort of Christmas tree type pattern there. This gentleman had ichthyosis, different distribution, but widespread. And this guy had erythrodermic psoriasis, total body involvement. So all of those are widespread distribution versus localized distributions. The next thing that you do is you kind of say, well, what's the configuration of the lesions with respect to one another? And there's a lot of very cool, beautiful configurations we see in dermatology. And, you know, if you're not a dermatologist, you don't know how to describe these, you know, linear, zoster-form, polycyclic, nummular, like a coin, guttate, like a drop, herpetiform, closely grouped, agminated, kind of a group of sheep, corymbiform, where you got a mother lesion with a little daughter lesion surrounding, milliform, like a bead. So this little kid's got some linear lesions. He's got some agminated lesions there. These are flat warts. This is a polycyclic annular eruption of someone with tinea corporis, and then this is a linear lesion of allergic contact dermatitis. So those are all the kind of configurations that we get. And sometimes those like that lesion on the right, nothing else in the world does that except allergic contact dermatitis. So you can, with that kind of linear distribution like that, not obeying any Blaschko's lines or anything like that, you can just make a definitive diagnosis of poison ivy in that case. So it just shows you, you don't need a biopsy. You know, you look at that, and once you have done this for a while, it becomes kind of almost like an instantaneous recognition diagnosis. Now, the next thing you need to know are what we call the fundamental lesions of the skin. Some people refer to these as primary skin lesions, and every dermatologist needs to become an expert at this. So you need to know these just like you know your telephone number, you know, your address. So this is something that you're going to become. These are the basic vocabulary of skin lesions and primary lesions of the skin. We like to call them fundamental skin lesions. Dr. Ackerman, when I were working on this thing, and primary is okay, but fundamental is kind of interesting. Just means it's kind of the fundamental building blocks of the way that skin lesions kind of present themselves. And I'll go through these really quickly. Like a macula is just basically, you can't feel a macula. It's just a small color change in the skin. By convention, it's like less than a centimeter. This is vitiligo. And some people talk about the difference between macules and patches being greater than a centimeter. So this is a lady with a blue nevus, a type of nevus of Odo on the eye. And papules, this is probably the number one fundamental skin lesion that we see. These are little papular lesions in the skin. And you have to be thinking in your mind, well, why is this papule there? Is it involving mostly the epidermis, like here? Or is it involving the epidermis and the dermis, or just only the dermis? And so you need to be thinking about this when you're looking at patients, when you're seeing them clinically. What's the surface of the papule? You know, is it papillated? Is it digitated? These are stucco keratoses. These are purely epidermal papules. There's nothing in the dermis here. If it's a dermal papule, why is it a dermal papule? Is it a deposit that's there? Is it a neoplastic cell that's causing it? Is it an inflammatory cell? This is lymphomatoid papulosis. These are all inflammatory cells in the dermis causing these lesions. Is there a combination of epidermis and dermis? So these are all things to think about. This was a little lesion of chondrodermatitis in this guy's ear that was causing that. And then you want to ask if the follicular structures are involved. There's anything coming out of the hair follicles. There's a little patient that had keratosis pilaris, so these little tiny spines coming out of his hair follicle. And plaques, these are just broad lesions greater than a centimeter, where the greatest plane dimension is kind of more horizontal. And just like papules, these can be epidermal mostly, they can be dermal mostly, you get the same kind of changes. So those are all basic things there. These were dermal plaques here, a lady that has mostly lipid-laden histiocytes, xanthelasma. So nodules, you just think, well, these are just papules that get bigger. And then tumors are nodules even bigger than that. And so again, you want just the same kind of thought process goes on. Is it epidermal mostly? Is it dermal mostly? Is it superficial? Is it deep? If it's a deeper lesion where I can just kind of barely feel it, what kind of biopsy am I going to need to do to sample that? Is it low domed, high domed, umbilicated? This is a juvenile xanthogranuloma comprised of histiocytes and some inflammatory cells there also. When you get really deep, you can maybe sometimes only feel these lesions. So if you get like a deep neoplasm, say in the subcutaneous fat, and again, you have to take a deep biopsy to sample these type of lesions. Now, this was a tumor of a dermatofibrosarcoma protuberans, and this is a lipoma. So again, these are deep lesions, and they kind of tint the skin overlying the neoplastic process. Blisters, we talked about that a little bit before, and these are basically small little blisters in the skin. And again, you've seen this picture, so I won't belabor that. And this is herpes infection, again, seen clinically. And these are little small acuminate papular vesicles of allergic contact dermatitis here. Bullous, just a big blister. Gets larger, same concept. And again, this is bullous pemphigoid. And so these are little blisters that got induced from freezing liquid nitrogen therapy of actinic keratoses. And then pustules, a collection of neutrophils or eosinophils, either within the epidermis or within follicles. So again, they don't always have to be follicular, like say pustular psoriasis, for example. Here's a nice example of a bacterial folliculitis. And this is pustular psoriasis. So one's epidermis and one's inside the follicle. You can get all sorts of changes that are mostly due to the cornified layer. Sometimes you make a diagnosis purely on the basis of cornified layer material. So scales, basically that's sort of a flat excrescence on the surface of the epidermis, like psoriasis, like in this picture here. And you can get orthokeratosis or parakeratosis, where there's retention of the nuclei. And you get different types of scale, if depending on whether it's basket weave, compact, or laminated. This is a patient that acquired ichthyosis, and you can see how dry and branny that scale is. Crust is where you've got both some, usually some keratinocytes or some cornified material in there with or without red cells or white cells. So again, this is a crust, and we talk about serous crust, hemorrhagic crust. And this lady was undergoing radiation therapy and developed this crusted lesion under her eye. And of course, scale crust is where there's some squames plus red cells and some serum. And this is a patient that had psoriasis. These lesions were kind of crusty. Keratosis, again, lots of different sort of interesting manifestations of these. You get the scales, spines, spikes, cutaneous horns like you see here. So usually something like this, there's something going on underneath the epidermis that's driving that. But the main change there clinically is a cutaneous horn. So you ask yourself, well, why is that horn there? You could lose the epidermis in an erosion. And if you lose epidermis plus dermis, we call that an ulcer. And erosion won't scar. So this is a little superficial excoriations here. But if you lose epidermis and dermis, then that will heal with a scar, like this person had this horrible morphia or scleroderma, sclerodactyly with these ulcers here, and you can see her skin's bound down there. An eschar is a tight, basically a brown black zone of devitalized tissue that sloughs with an ulcer underneath it, usually seen in burns. But patients that traumatize their skin, they scratch their skin, or they may put black salve on their skin for one reason or another, they can get eschars there also. Or a blistering disease like a fixed drug eruption that heals, that can give you an eschar at the surface as well. And then the last couple of lesions, fissures, these are just little cracks in the skin, usually seen in things like psoriasis and whatnot, little fissures here. So this person had psoriasis, all these little fissures in their skin. Atrophy, you can lose either the dermis or the subcutaneous fat. It's really hard to appreciate pure epidermal atrophy. Usually if something's atrophic, you'll either have some alteration of the papillary dermis, you get that kind of cigarette paper wrinkling, or if you lose the reticular dermis, it's kind of almost an outpatching like an anetoderma, and the subcutaneous fat, it's more of a gully. So this would be somebody that's got superficial papillary dermis atrophy with that cigarette paper wrinkling. And this person's got lipoatrophy, and you can see it looks more like gullies in the skin here. Telangiectasies, just dilated blood vessels. That's not really a macule or a papule or whatever, so it's kind of a special lesion. And this lady on the left has crest syndrome with all these mat-like telangiectasias. The lady on the right's got a telangiectatic hemangioma. You can't feel that. It's just, basically purely color change. And then burrows, basically tunnels, and these are formed by organisms like scabies on the left or cutaneous larva migrans on the right. And then cords, these are like string or rope-like structures that are either in the skin or beneath the skin. And this was a person that had a palisaded granulomatous dermatitis associated with connective tissue disease, which can give you a cord-like granulomatous process in the skin. So those are the fundamental lesions. It's a brief, quick sort of overview of those, but you need to know those basically kind of like the back of your hand, if you will. Now, then you remember that doesn't get emphasized enough in dermatology is that there's chronology that's important here. And every disease, just like everything, has got an early, a fully developed, and a late stage form. And so depending upon when you see the patient, things may look different. If you see somebody really early, they may just have a little macule, a little color change in the skin, or a little tiny papule, and those can evolve into plaques, nodules, tumors, etc. Here's urticaria. And so if you look carefully, there might be a little tiny red macule here, but then those can soon develop into these large, giant plaques, giant urticaria over here. This guy started out with this discolored sort of purplish change in his skin. He said, well, that's pretty early on in the evolutionist process. 5 days later, he's on the autopsy table. He had calciphylaxis and basically infarcted his entire skin. So this is early, this is late. So depending on when you see a patient, things may be more apparent. This is more obvious that something bad's going on here. But here, if you say, this could be a lot of things, it's early, we need to be careful, you want to maybe try to prevent that. So chronology is important. Some other things, physical diagnosis wise, talking about looking at adnexal structure, size, shape, color, etc. So this is kind of where you're really going at high magnification and looking, say, at a papule, for example, and asking yourself these various questions. Does it involve a follicle or not? What's the color of it? Look at it basically with your dermatoscope, look at it on end and profile. So we want to ask ourselves if follicular structures are involved or if adnexal structures are involved. And this is lichen planopilaris. This is gone. This hair is never coming back. Permanent scarring alopecia, the follicles are completely destroyed here. And this guy's got a lymphoma. And notice how the lymphoma doesn't care that it's got background hair follicles there in his eyebrow. It just kind of marches right through them. Benign processes don't involve follicles. So cancers, they don't care about follicles. They'll just wipe them out. So that's helpful to know too. Look at size, shape, color. All these are very important. So these are polygonal flat top papules with a white scale that's got these Wickham Street on the surface. If I call up a third-year resident at 3 o'clock in the morning and describe that, then they're going to instantly say lichen planus, even without even doing a biopsy or anything else. So you just know that. Here's a malignant melanoma. Broad, asymmetrical, poorly circumscribed. It's got color change in it. It's got black, it's got brown, it's got white, this sort of bluish gray coloration. So those are all things that you want to describe as well. And then looking at color, again, this is something, again, that separates the experts from the non-experts, because basically you can get different types of color. If you talk to an intern and say, oh, that's white. Well, what kind of white? I mean, is it sort of dead white, like in vitiligo, where there's no melanocytes? Is it kind of a milky white, like in lichen sclerosis? Is it white because there's no blood there, like the person's fainted, they get ashen white, but they've got melanin there. Their skin's not white because there's any blood there anymore. So this is vitiligo, no melanocytes there. Look how the color change of that versus lichen sclerosis. There are a lot of melanocytes in lichen sclerosis, but the sclerotic collagen gives it that sort of milky color. It's not quite as white as you see with vitiligo. Same thing with reds. I mean, we can get brilliant, bright red. You can get kind of bluish purple, depending on where the blood vessels are. This is a kid with a hemangioma, so-called strawberry hemangioma. Look at that sort of almost port wine color to it, if you will. And this was an inflammatory erythema. This was a person that had lupus, and their skin is brilliant, bright red because of the inflammation. And then this is a beautiful photograph of someone that's got 3 things here. They have this orange salmon color of pityriasis rubipilaris in the background. They've got that little hemangioma that's bright red, and they've got this benign keratosis that's kind of pinkish. So it shows you the spectrum of different red color change that you can see. And the same thing is true with black and brown, blue, different colors, depending on where you look. If melanin is in the cornified layer, that looks black. It's like the squid ink, if you will. It's jet black. We take that same melanin and move it down, it becomes brown, and you get it further down, it becomes kind of a bluish gray color. So this was a patient, the lady on the right, that's her normal skin color. The guy on the left is her father, and he was using silver containing eye drops for many years and developed argyria, and his skin got just really jet black. And this little kid's got neurofibromatosis. That's also melanin, but it's brown. It's cafe au lait here. It looks like coffee, if you will. The guy on the right's got a carbon tattoo, so that's black. That's not even melanin. And he had a fireworks exploded in his face. Then you want to look at the actual lesions themselves. Is it smooth? Is it rough? Is it round? Is it cool? Is it warm? So this is why photos are never going to replace seeing patients in the clinic. This is a classic micaceous scale of psoriasis. You can imagine what this would feel like if you rubbed this. And these are steatocystoma multiplex. These are going to be kind of rubbery, blottable lesions. They're beneath the surface of the skin. And then you want to feel them. Are they soft, hard, rubbery? Are they fixed to the underlying skin structures? These are neurofibromas. You can imagine it's going to be rubbery, like a rubber ball. This lady had metastatic breast cancer. It felt like a rock. So these are, you really need to feel skin lesions also to really be able to really do physical diagnosis. And then sometimes we do ancillary testing. We rub the skin. We may take a pin and stick it, see if there's any loss of sensation. We have other things like taking a Woods lamp. We scrape things. We push on blisters. Those are all things you're going to learn about in the clinic. Also, this person had urticaria pigmentosa. Rub the lesion, and 5 seconds later, you get this wheel and flare reaction here. So the last thing we do is a good clinical dermatologist is we picture in our mind where the pathology is going. So hopefully in your grand rounds conferences, you're attending to say, okay, where do you think the pathology is? And what do you think the pathology is going to show? And that's where you really can separate yourself from non-dermatologists, because they don't know what pathology shows. The PAs get no training in dermatopathology. They need training in dermatopathology, but they're not getting it. We're trying to give it to them because they're practicing dermatology and they're not doing as good a job as they could be because they don't have this information you're getting today and you're going to get over the next 3 years. So again, you want to come up with synthesize all this information. So here's an example of kind of how it works. And every fact is critical here. So a 3-week-old girl, that's important. Age, sex, scaling, erythema, location, irritable, small for dates. Every one of those factors are critical. Widespread eruption, crusted papules, involving the lines of Blaschko, clinical diagnosis. That's probably the least important, but they go down and rule out epidermal hyperkeratosis. With all that information, when you get to be a third-year resident, you can come up with a differential diagnosis very quickly with that. And this is what the kid looked like. I took a biopsy, and it looked like this. It was spongiotic dermatitis with lots of eosinophils, with these dyskeratotic keratinocytes. You guys know, the upper level residents know exactly what this diagnosis is, incontinentia pigmenti, and you can make that diagnosis specifically. You don't have to hedge it or anything like that. Now in the lab, and when you're working on these unknowns, you're going to get a biopsy. And then it's basically, we look at it initially without any information, then we formulate a differential diagnosis. Then we look at the clinical information and we put 2 and 2 together. So this was a shave biopsy. It's an inflammatory skin disease. It's taken from near volar skin. It's got a very dense diffuse inflammatory infiltrate. There's all these holes in the epidermis. So why are those there? Is it spongiosis? Is it ballooning? Is it one of those 3 patterns we just talked about? We go to higher magnification, and again, we see there's this pallor of the epithelium. And this is a classic example of ballooning degeneration. These cells are filling up with liquid. And they're getting so filled up with the liquid, they actually form these little blisters that then sort of pop. And so we come up with a differential diagnosis for acral ballooning degenerated, inflammatory skin diseases. So we have a differential in our mind. So maybe this is a parapox virus infection. Then we turn down and look at the information, and we get this information. That it's a sheep rancher from Central Texas who came with this boggy plaque of his hand for a week. And we don't care what they were thinking, but we know why they thought that, because it was a bullet. It was this very indurated, boggy lesion that looked like this. And when we take that information and couple it with the pathology, we can make this specific diagnosis of ORF because he was exposed to sheep and goats. So we can make that diagnosis with specificity. So just a couple of closing points. We all have EMRs today. The good news about EMRs is that things get put in electronically. The bad news about EMRs is that they are, spit out these robotic canned descriptions that don't often make sense. They have dermatitis unspecified. Well, they shouldn't be allowed to have that as a choice, if you ask me. They shouldn't allow that. And here you see one of our clinicians, she didn't like that, so she had to scratch it out and then write on there what she thought because she's dealing with a complicated patient. So unfortunately, these EMRs don't help us. And a lot of people submit things like neoplasm of certain behavior for any diagnosis, including inflammatory diagnoses. It's not good. So don't let that hurt you. Don't let it get in your way. Don't let it be like Ken Jennings playing Watson. The idle brain is the devil's workshop. You don't want this to happen to you. So make sure those EMR programs don't dilute the clinical information that we need to make diagnoses when you're submitting biopsies. So in conclusion, take the right biopsy for the condition you're dealing with, treat your biopsy like a treasure, and then go through these algorithmic approaches when you're making diagnoses, and you'll do well in these conferences, and you'll do well when you're practicing dermatology. So that's it for the lecture this morning. I hope you guys enjoyed that. I hope it's helpful to you. If you have any questions about any of this stuff at any point in time, you always feel free to call me up, send me an email, ask me any questions about it. And we will be applying and using this information when we start doing our conferences. So that's it for this morning. Hope you guys have a good week, and we will see you probably in September when we first start doing our unknown conferences.